You're watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. Today's topic, what's new in the world of pain management? My first guest is an interventional pain management physician who's getting amazing results with his patients. We're talking today about some of the therapies like spinal cord stimulation to avoid drugs and extremely invasive surgery. He's an expert on the topic. He is the go-to pain management doc in the Northwest Indiana area. With us we have Dr. Tarek Shahbandar. Dr. Shahbandar, welcome to the program.
Thank you for having me. It's nice being here.
Good, good. Yeah. Now, you are double board certified, right?
Yes, I am.
What?
Anesthesiology and pain management.
Okay, good. Now, for people that don't know pain physicians of Indiana, like who's the typical patient you see?
So we don't typically have a typical patient per se. Our most common patient that comes in would be someone with back pain.
Okay.
They might have neck pain. A lot of these patients come in from our colleagues who are spine surgeons. They might have had multiple back surgeries. We have lots of treatments, like you mentioned, spinal cord stimulation to stop pain, even if you've had multiple back surgeries and you continue to have pain. So those are the most common things. We also have, there's no real most common thing, honestly,
Okay.
because there's let's say there's over 300 nerves in the body from head to toe, and we can cover any of those nerves to cover almost any kind of pain.
So you, look, as pain physicians, you guys have identified all the nerves in the body? Is that right?
Well, as physicians, yeah, we know all the nerves in the body, and those nerves cover areas of the body, obviously, and those areas have pain. So we can cover with nerve blocks or different procedures. We can reduce pain to any portion of the body where those nerves are traveling, which is basically the whole body.
Now, we were talking in the green room, and I said, I've had medical doctors on the program, mostly primary care physicians, things like that, and they don't like the pain patients because it's an unhappy group of people. But you like dealing with them. Why?
Well, I like to make them happy. We like to turn that around. And, as we were talking before, there's sometimes people will be telling me their pain, and I'll have a solution for them. And that's what makes us happy. So, yeah.
Do you see people getting, like, for example, in your career, have you had people that were able to avoid surgeries with some of the...
Absolutely. Yeah. All the time. Even surgeons will come to me as patients sometimes.
Really?
To avoid surgery themselves. And there are blocks that will help reduce pain. Very commonly we do transfemoral epidurals or epidurals, for example, if someone has a lumbar disc herniation and they're at the point where they're having a lot of pain, and we can put a little medicine on these nerve roots that are irritated from the discs that are herniated or from the chemicals released from these discs.
Like a bulging disc?
Like a bulging disc. It's good, like a bulging disc.
And they start to leak, you said?
Yeah, they leak chemicals. Okay. There's irritants from within the disc that come out. The disc is in the back. It's like a tire. Okay. The outside of that tire outside part is called the annulus. Okay. And then the inside is like a jelly. It's like nucleus of the disc. And that disc, when it pushes, that jelly starts releasing irritants or chemicals
that land on the nerves?
That are on the nerves in your spine.
Interesting.
And that shoots down the leg or the back. And by just putting a little medicine with anti-inflammatory medicine around those irritating chemicals, wash those chemicals out and reduce the irritation on those nerves.
And some people get better?
They get better instantaneously.
So even though you're dealing with pain patients,
yes,
you said that like weekly, daily, you hear good stories.
Oh yeah.
Of people reversals.
Yeah. I mean, there are people when they're in a lot of pain, they're hard to be around, they can't get their work done. So they come in and we do a nerve block, like an epidural that we talked about, and they're back to work, they're friendly with their family, and we see these things all the time.
Now insurance covers, I mean, just about everything we're talking about today, insurance covers.
Yes.
Like HMOs, PPOs, Medicare, is that right?
Medicare covers this really well.
So if you're 65 plus, this is going to be covered?
Yes.
Okay.
Most everything we're talking about is covered by insurance and Medicare.
Okay,
yes.
Now I told you, I live on a block where there's a bunch of wealthy 72-year-olds in that range.
Right.
They all have back problems, and they've had so many procedures. And after talking to you, I'm saying, have you ever seen an interventional pain doc? Not one of them nobody's heard of it.
Right.
Right?
Well, we're usually, because we're a specialty, usually they come to us from either their primary care doctor or they're seeing a spine surgeon. But these people can come to us right away. It is possible, yes.
Do you need a referral to see an interventional?
No, for most insurances, no.
So they could call you directly
Yes, they
if
could.
they wanted to?
Yes.
And you said you have a great relationship with the spine surgeons?
I do.
And,
We do use spine surgeons and neurologists and other specialties. Obviously, we all work together. And it's multidisciplinary approach to some of these problems. And it's not like you're just coming to me necessarily. Sometimes you need more than one. Physical therapy is very important sometimes. It could be medications. Now we try actually very hard. Patients think of us, as far as pain specialists, think we're just the guy who gives you the pain pill or the opiate, which is not the case at all. Actually, we're the guys who will get you off the pain pill with these procedures or physical therapy or other modalities. That's actually what we work on. So if you're a good pain specialist, you're trying to get people off pain medications, feeling better without pain medications, back to work.
Does that happen?
Oh yes, that's like my favorite thing. That's like what we do. That's what we do, and that does happen. Yes.
So one of the reasons I invited you on the show is to talk about spinal cord stimulation.
Right.
What is it? How does it work? And what type of pain problems is it good for?
So, spinal cord stimulation is a big topic. It basically mostly used for patients who have multiple back surgeries. And they've developed some scar tissue in their spine, and nothing else is helping them. They're having severe pain in the back going down their legs. And basically what it is it's a small electrode that we place in the spine, like an epidural, like a catheter, but that electrode basically blocks the pain from moving beyond it. So it's basically tricks your body into not having pain. Instead of pain, you feel a sensation like you may not feel anything, you may feel like a nice touch or a warm or a small
like a tickle
buzzing.
Kind of a thing?
Could be a tickle, maybe nothing, but it basically blocks that sensation, completely blocks away pain.
Okay, so with this spinal cord stimulation, so you kind of aim it at the nerve. Is it radio frequency? What is it?
No, the radio frequency is something else that we do as well. But it's basically an electrode that sits in the epidural space. And
so it's electrical stimulation that confuses the signal to the brain?
Yeah, it basically blocks the signal to the brain.
Interesting.
And there's a big name to that, but it basically it stimulates touch sensations, and those touch sensations overwhelm the pain fibers, which are smaller nerve fibers. So it's easy to overwhelm them. Luckily, that's a very great thing because now we can stop those pain signals from going to your brain, or reducing it significantly.
For some people, is it somewhat of a miracle? Spinal cord stimulation?
Yes, it is. It's really been a great, and the technology, this thing, some people are maybe watching and they're like, well, my grandma had this in the 80s and it didn't work for her. This technology has gotten so much better. Every year it's getting better and better to the point now where it's really working phenomenally for a lot of people. So I have this great story of one of my patients. And she did give me permission to bring this up today. So I have this patient who's a professional horse trainer, and she had severe back pain radiating down her leg. She had surgery, and the pain unfortunately did not get better. That does happen sometimes. Her pain got worse, and she came to my office. I mean, she was down, depressed, and I could tell she was a very active lady. And I talked to her about this option of a stimulator. And I actually had to do some blocks and some other things first because she didn't like the idea right away. But once we did it, what we did first, of course, is a trial, and I was telling you about this. This is the nicest thing about this. To me, it's one of the nicest things about this.
What is this trial you're talking about?
So the trial is, like before you have surgery, you're not testing, you don't get to test drive your surgery, right? You're not, I'm gonna have this spinal fusion. You're not gonna be able to test drive your spinal fusion beforehand. With a stimulator, we can put a catheter in the epidural space that's not surgically implanted. It's just a temporary catheter.
In the office, you're doing this right there in the office?
You can do it in the office. Some people are nervous, so they have to go to a surgery center, but we can do this in the office, yes. We place this catheter in, and we turn on the device, an external device, and they see right away if they're having the relief or not. They can sense how it is. A lot of people cannot wait, because it usually takes about a month once the trial. Sometimes it takes a month, sometimes it takes a couple weeks.
So you send them home with this temporary, was it like taped to their back or something?
It's taped. They don't take a bath, please. But yeah, it's taped, and you basically go home and you live your life. And
some people are going,
they can't believe the difference. I mean,
just stop. It interrupts the signal to the brain.
That's one of the theories on how it works. Yes, they don't feel their pain is much reduced. And they can't. Most people cannot wait to get the real thing placed.
I interrupted you about this the horse trainer. So what happens with her?
Oh yeah. So, yeah, she got that relief, and she comes to our office from getting the stimulator, and it worked great.
Okay.
So we go ahead and implant the device.
Okay.
And
what's that like, by the way? Downtime, pain?
It's outpatient procedure.
Okay.
So you're usually in and out of usually it's the surgery center and within that day, and you're home and you get some pain medications, and you're going to heal. It's a quick healing process, so it's really not much to it.
You told me on the phone it's robust. Does that mean it works for a long time? Yeah,
well, it works maybe also for a lot of reasons. This is just one of the reasons it works, but it does last your lifetime. That's a whole nother story. Can I get to how robust it is? I want to get to that.
Well, tell me, go ahead.
Okay, so I had one patient I hadn't seen in 14 years. I've been practicing for 17, 18 years, and she was one of the first people I put a stimulator in.
Okay.
And I just, because I had started my practice in Northwest India, and I went and taught at University of Illinois, and I came back, and she was looking for me because for the last half a year, stimulator stopped working because there's a battery in it. You have to change the battery. So it was working. She didn't take any pain meds. She didn't have any problems for 14 years, and she was looking for me. She found me again, on the internet, and I was able to change the battery, and it was working again. So it's been almost 17 years. That's what I meant by robust. I mean, it's just been working great for her this whole time.
So for some people, it's big. And the nice thing is you're able to, I guess, test it ahead of time.
Yeah, so you can test drive it or test it beforehand. You do the trial, and then you implant it.
Is this, when you say neuromodulation, are we talking about the same thing?
It is the same thing.
Okay.
It's the same thing, yeah.
And so, look, just sitting here listening, it sounds good, right?
Right.
Without medication. Why aren't they all doing it? Are they worried like it sounds like a surgery? Are they worried about something being implanted in their body?
Yeah,
What's the hesitation?
Well, some people have heard that, this person has done it or that person has done it and it didn't work for them. And this was usually someone from, 15, 20 years ago or 30 years ago. And it doesn't work for everybody. So some people hear this story and then they think it's still the same way, and it's not. It's gotten a lot better. The other hesitation is, it's another surgery. They think, they already didn't go very well the first time, so why would I put myself through something else? So, and I can understand that. Honestly, we also want people, we want to select the right person for this procedure, right? So we're not just putting this in everybody. So we want to make sure if you are selected that you are going to have a great outcome. So we're also not.
So if you, with your judgment,
right,
decide to do a spinal cord stimulation, does it work more than half the time?
Oh yeah, yeah.
Okay, and you're testing it first.
Yes.
So if it doesn't work on the test, then no need to go with the
right. Of course not. We would never implant it if the test doesn't work. Yes.
It sounds good. So this is one of those hot topics.
Right.
Is this kind of like the future of pain medicine, where you can interfere with the nerves, the signals to the brain?
Right. I think it is. It's a future. It's something that's getting easier to do. It's the technology is improving every year. So I do think it is one of the futures of pain. Our field has a lot of very interesting things for the future. I think this is definitely one of them. Yes.
We talked about back pain, but what about like neck, shoulder, sciatica, or leg pain? Does spinal cord stimulation work for that?
Yeah, it can work at any portion of the body, even peripheral nerves like around the knee.
So as long as it's nerve pain?
Yes.
Am I understanding that correctly?
Or even headaches. We have patients where they have something called occipital neuralgia, where the pain shoots into the back of the head, nothing else. This is, again, not something we do right away because there's lots to do first. But if it's nothing else has helped, yes, we can go to other areas of the body. So yeah, it works in multiple places.
I had an interventional pain doc that I was talking to, and he said, our goal is to kind of avoid drugs and surgery.
Yes.
Do you feel that way too? Or invasive surgery? Do you feel that way?
Yeah, of course. We would try to avoid, well, that's what the whole point of this is, the opioid crisis, that we would reduce pain without, honestly, right, we can write opiates to people and turn them into zombies. That's the last thing we want to do, right? So we would like to focus on things that are not addicting and not invasive. That, of course, that would be the first thing that we would try to do.
Have you had people that were on some like opioids or I don't know the medication classes, but they were on some heavy medications that because of spinal cord stimulation, they were able to wean off or get off completely?
Yes, multiple people. And most of them by far can at least wean down quite a bit. I mean, they may still have one or two meds here or there just to help.
So the neurologists who oftentimes are sent to, do they do this as well?
No. Neurologists don't typically do this. It's usually most commonly done by interventional pain specialists.
Okay, good. So what's your number one? Is it mostly back pain or neck and back pain or neck pain?
Well, it can be neck or back pain. Their number one reason for, it gets me back to the other question, I'm sorry.
Okay.
But the number one reason is back and leg pain from multiple back surgeries or back surgeries where they can't benefit from another back surgery. That's number one. And then the number two reason is actually something called chronic regional pain syndrome or reflex sympathetic dystrophy.
What does that mean?
So this is a difficult disease that we as interventional pain specialists have to treat. Or we'd love to treat, actually. I shouldn't say have to treat. We love to treat. But it's a very difficult disease. Chronic regional pain syndrome is a disease where someone's had some injury, something's happened where they have burning pain into a limb. Usually this is how it runs.
Okay, so burning pain in a limb.
Yes, so it's some kind of burning pain into the arm or legs from, it could be an injury, it could be even just an IV placement. It's a very strange disease, but they'll have an entire limb that's completely out of control burning pain. They'll have discoloration. There's characteristics. So this is where spinal cord stimulation, especially if it's run its course, this disease has run its course for a while, can be very beneficial. It can actually put this disease into remission.
Really?
So, yes.
So you've had it happen?
Oh yeah. This is one of the few things we can offer this patient at some point where this disease can, get much improved. We can really improve, like we always talk about this improved function where they are able to get back to work or they can move that limb. Some people can't even move their limb from this disease. Like they literally haven't moved their limb, they can't walk and they can't handle water and they're taking baths or they're going to work. So when you bring someone from a pain of 10 to 3, this is life-changing for people. So I hear this a lot in my practice where people are so upset that they can't cut their grass. Right?
Okay.
It's like their grass is growing and they can't cut and they're very upset because they have pain. You take someone to 10 to 3, they're going back to cutting. That's a big deal for people. They're cutting their grass, they're getting things done around the house.
So the grass thing comes up a lot?
For some reason that seems to be, especially this summer, it's like the grass growing too fast. They can't catch up with it. And that's very bothersome. That's just part of the problem, right? It's not, okay. But that's what they bring up because it's a visual thing that they see. It's growing and they can't do anything about it. And it's very frustrating. There's too much pain So it's not just that, right? It's everything in their family. It's like they're happier to be around people. Their grandchildren can visit them.
Because when you're in pain, it's no fun to be around people in pain.
Right. And if you don't mind, I'd like to tell you another story about that.
Sure.
It's not necessarily about spinal cord stimulation, but it is something similar. I have a doctor's wife, in where we have our clinics. There's lots of doctors, and there's a doctor's wife that she'll come into my office. She is 92 years old, and she has a disc herniation in her neck, and she's scared to death to have surgery. And really, the spine surgeons say she doesn't really need surgery, but she'll have this disc will flare up and irritate every nerve in her body. Like she comes and she can't even walk. I feel bad for her. My staff all know her. She comes in, so we set her up for an injection because it works for her. And she came in to me last time. She's like, "Look, Dr. Shahbandar, I just want to have a nice meal with my grandkids. They're coming in.
Okay.
And I just want to have a nice meal." I think it was Thanksgiving, but I can't. Okay. But it was just, she really wanted to have this Thanksgiving dinner with them. We did the injection, and the next time I saw her, I was like, "Were you able to have the meal?" She was so happy. She was able to have that meal, and she was pain-free during that time. So, the stimulators actually, when we do things like that lasts a lifetime. Some of the things we do don't last a lifetime, but they can be.
It can last a lifetime.
It can last. Yes,
okay.
They can last a lifetime. The injections may not last a lifetime, but we can cover pain, let's say a week, maybe a year. Depends on the type of injection we're doing. So it does last.
But if you get them out of pain, don't they become more active again?
Yeah, they get more active. We were getting that. They can cut the grass as one of the many things. They can be with their grandchildren. They can go swimming. There's lots of things people do, and that makes a big difference. When we talk about function, that's what we're talking about. Function is those things in life that you do that make your life worth living, right?
You say they can pick up socks off the ground, or
that must be
clean things in their house. They just
that's another thing. Yes, they cannot clean or really do anything, and they go to having things that they can do in their life.
Now, I know I invited you on the show to talk about spinal cord stimulation, but you've got like 20, 30 things
Right.
you can do and you said you're aggressive with pain. Could you tell me what you mean by that?
Yeah, so the earlier you treat pain, the less likely it can get severe to the point where it's disabling. So the earlier you treat it, the more function you'll have in your life, the more things you can do.
So let's say disc herniation.
Right.
What's the advantage to doing some of the things you're doing early? Because I've been told people wait until they're in so much pain they can't take it. So why go in early at the early times? I mean, it seems obvious, but help me understand.
You can literally help you go back to work, like my father's story. Or honestly, there's an orthopedic surgeon in the hospital I work came to me. We were able to do a lumbar, an injection basically, and he's now busy in the OR again. I mean, it makes a big difference. If he were waiting around, not doing anything, he wouldn't have been able to go back to work as quickly.
Good.
And then once you're disabled, it gets like psychologically, you can get depressed. You start wondering what you can or can't do. So
they get really depressed, you say?
Yeah, they get really depressed, yeah.
Then the weight gain, I guess, from lack of activity and everything else.
Yeah, that's the last, and that's the other thing that we used to say, like in the 70s and 80s, maybe they would say, like, someone has a disc hernia or something's going on, they're having some severe pain, like bed rest. But we don't want that. We want you functional right away. Push yourself through that. Get past that point.
We are short on time, but I have a couple things I want to ask you right away, and one is shingles.
Right.
Because you do things for shingles. Right,
and it's something I don't think it's taken advantage of enough. And shingles is very painful. If you've ever had shingles, you get like a burning pain it's a dermatome they call it. It's like a very specific way that it goes. And these patients are usually treated with antivirals, which is important, but sometimes their pain is out of control still. And so we have nerve blocks, just like we talked about, where we can get those nerves, or we can freeze those nerves so these patients will not have the same amount of pain. And that may actually reduce the chance of postherpetic neuralgia, which is a continuous pain for life, which hopefully, I hope none of you guys get it, but it's really terrible, where someone continues to have that shingles pain for life. So by doing this early, we may reduce the chance of...
But doesn't every shingles patient know this? I mean,
No.
What I'm saying is, if you get shingles, don't you know, there's other things you could do?
No, in fact, a lot of times you'll read there's nothing else to be done. And it's too bad, because there's actually something that can be done for that kind of pain.
Okay, good. Radio frequency.
Yes.
You're using it in different areas of the body?
Right. Yeah, really also done everywhere. This is a technology where I call it, sometimes it's referred to as burning nerves. I like to consider it like stunning these nerves.
What do you call it in your industry?
Radio frequency ablation.
Okay, ablation. Okay, I got it.
Oh, ablation. Okay.
Okay.
Yeah. So ablation is cervical, or like radio frequency ablation is a technology where we can basically ablate or sever sensory nerves that don't have any function. So these aren't nerves like, oh, why would you burn out these nerves? They have no function other than let you know that you have pain. So you have like an arthritic knee, or you have arthritis in your spine, and these nerves are letting you know every day of your life that you have this pain, right?
Okay.
And I got the point already. You don't need to know that anymore, okay? You don't need to know that you have that arthritis in there.
So with this radio frequency, you pointed at these nerve endings or whatever.
Yeah. And then we just
burn it, heat it.
We heat it or burn it or lice it in different ways. And that pain will go away for 1 year to 2 years. So let me give you an example. I have a patient who comes in. Actually, he did not come in himself. He reluctantly came in. His daughter brought him in. His daughter is one of my patients. He had severe neck pain. He was told there was nothing that could be done by his neurologist. His pain is worse when he rotated his neck. He didn't have a disc herniation.
Okay.
But what he had some arthritis in his neck. And so we went and did an injection around where he had arthritis in his neck, and he came back. I swear he was smiling. I didn't even recognize him. And his daughter was like, I told you so, Dad. And he's like, he was worried rightfully that this pain would come back, and it did. We then proceeded to the cervical facet radiofrequency ablation, and he's been great.
Wait, you do imaging first to make sure that they're candidates.
Right. So there's.
And by the way, are you looking at a screen when you're injecting?
Yes, of course.
Okay.
Yes. So we are looking at. We have a fluoroscope and a screen. So we're doing this live with X-ray technology while we're doing that. There's other things where, of course, it's not just jumping in there and doing this. Hey, I got something for you. There's the physical exam, the story the patient has, what they've already been through. They've been through physical therapy. They've been through so many things sometimes. But we take all that into consideration with the imaging, usually an MRI of the cervical spine or whatever it is, we look into all of that, and then while we're doing the procedure, we're also using live X-ray imaging or fluoroscopic imaging, and we're doing things as safely as we can. I'm going to cheat to make sure that these patients get the safest procedure possible. I'm not going to just go blindly doing something. I'm going to make sure.
When you say that, is that being done out there?
Well,
like they're just injecting wherever the pain seems to be?
That is not true, and I'll give you a story of my mother-in-law. I hope she lets me, she allows this, I think she will. So she had knee pain, she has arthritis in her knee. She went to, I don't want to say who, she went to another practitioner, and they did not inject her knee, they injected her in the muscle above the knee. And that's because sometimes some people who, let's say they're not trained as physicians, or they're not trained, like they're not board certified, the safer way to go, maybe not where to go, maybe in a muscle. And it was pretty obvious her husband's a doctor, her son-in-law, her daughter's a...
So you get a hold of her and what happens?
She's furious. So yeah, of course I do it right. And the difference, I mean, of course, like, she's biased, she's my mother-in-law, but she's like, can't stop talking about it. I mean, it's made, of course, make a big difference for her. So yeah, it makes a big difference. No, I mean, obviously using X-ray guidance, using the right technology, putting it in the right place, all those things are very important.
Now this is a big topic, and look, I look at your website and all these things you do. We haven't talked about stem cells, regenerative medicine, prolotherapy. I mean, these are all things you do for shoulders, knees.
Right.
And we just came on the show to kind of narrow the topic. But it's like as you say, multidisciplinary approach.
Right. Well, there's a lot of things we do, and then there's a lot of different providers we also rely on to help us.
Okay.
So yeah, there's multiple things going on, and that lot of those technologies that you talked about, especially some of the things like plasma-rich protein and some of the regenerative type therapies, the future looks very bright. There's just more and more coming, and looks very, very exciting. So we hope to be part of that.
Final message: somebody's watching this, they're in pain, and they swear, "I've tried everything," but they've never heard of an interventional pain management physician. What do you say to them?
Well, you can come and call us, and we can go over what you've done and what you've not done, and we may have some things for you that'll make you a lot better. So give us a shot, give us a call, right? And we hope that whatever it is.
I know you're a big center, and you have a team of doctors. Do they share your same philosophy?
Of course, they share my philosophy, and we all have the same passion to help our patients.
Okay.
And we all obviously talk to each other, and we pull each other in the rooms all the time. By the way, sometimes you may see two of us.
Okay.
So and so yeah, we're all working together. So.
All right. I want to thank you for coming to the show.
Okay,
Good
thank
stuff. You've been watching the Wellness Hour, news that makes you healthier. I'm Randy Alvarez. For now, I wish you good health.
Thanks for watching the Wellness Hour, the leader in medical news with your host, Randy Alvarez, the authority on health issues.